So I would treat this patient after reviewing the case study with Zoloft, 50 milligrams a day to start. And I would probably also add in some trazodone, a 50 milligram tab, half to one tab as needed at bedtime to help with his sleep. So my rationale for the Zoloft is that according to the symptoms that he is displaying, that he meets the criteria for major depressive disorder according to the DSM-5. And a study that was completed by Adjei et al. 2023 found that the Zoloft, and along with other SSRIs, improved patient symptoms 90%. So it's an appropriate antidepressant for this individual. I added the trazodone because he had reports of only sleeping 4 to 5 hours per night due to his thoughts were racing. Because Zoloft sometimes can also increase those symptoms of insomnia. So I didn't want him to have those experiences and have no way to treat it. So I would add the trazodone, like I said, just as needed, not scheduled, a half a tab to one tab at bedtime. And an article that I found from Scott et al. In 2021 found that improving the sleep of patients correlates with better mental health symptoms. So that would help with that as well. Some of the side effects that we would talk about for the Zoloft would be, of course, the sexual dysfunction, the GI symptoms, so his decreased appetite, nausea, diarrhea, constipation, dry mouth, all of those things. And then we would talk about symptoms for trazodone, nausea and vomiting, constipation, dizziness, sedation, fatigue, maybe some headaches, or some of the common side effects that we would talk about with that medication. Some education that we would talk about is that Zoloft, can take 2 to 4 weeks to start to notice any symptom improvement, and up to 6 to 8 weeks for it to work well, that there might be a dose increase that's needed to get him to the appropriate dose that's going to work best for him. We would talk about if he does experience some nausea, to maybe to try to take it in at night if his insomnia has not worsened. For the trazodone, I would talk about that he needs to make sure that if he's going to use that, he needs to take it where he's going to allow himself to have enough time to get a decent amount of sleep, up to 8 hours or so before he needs to get up. So that way that can not be in his system. He doesn't have some daytime fatigue from it. So that would be important as well, that he takes it earlier in the evening if he's having trouble sleeping, not waking up at like 2 a.m. and then trying to take it and then getting up for work at like 7 a.m. So we would discuss that as well, like an appropriate time for him to try to take that medication to see if it works. And I would remind him that it is to take only as needed. It's not a scheduled dose like the Zoloft. Because he is a healthy individual, according to the case study, there's really no labs that are indicated for him for either of those medications. However, it wouldn't hurt to probably get a baseline EKG, as trazodone can sometimes cause arrhythmias. But with him not taking it on a regular basis, I do feel like he's at a lower risk for developing that as well. I would probably plan to follow up with him in 4 to 6 weeks to see if he's had any effect of the Zoloft. I would encourage him to call the office if things are worsening before then, so we could get him in sooner if his symptoms are not improving or they have gotten worse. So one of the ways that we would know that the medications are working is his report of symptoms would improve, right? So he would start to be able to take care of himself better, because it talked about how he was not completing self-care, some of his ADLs. So those would probably improve if he was doing better. He would be able to report that he is sleeping more. He might be able to report that he is able to maintain going to his job, and just have a better outlook on life, and those suicidal ideations would be diminishing. Some of the scales that we could use is the PHQ-9. We should have done one at this initial assessment, and then we could do another one at his follow-ups to take the scores and see how he has improved on those. So I would justify increasing the dose based on his symptomology. So if he is saying that like he's felt that there is some improvement, but he feels that there could be more, or even if he says that there's no improvement, I would try to go up a little bit higher, maybe 50 milligrams a day. So up to 100 milligrams, and then have him come back in about 2 weeks to see if he has had any improvement at all. And just providing that education that it does take time, you know, for all of that. If I did not make any med changes and he was doing well with the medications that were previously prescribed, I'd probably have him come back about 4 to 6 weeks to ensure that the medications have remaining effective, and to make sure that the patient isn't experiencing any manic episodes. Because a lot of times, as we learned previously, that bipolar sometimes presents with depression as the first episode, and then it, you know, once they start to treatment, they become manic. As for ethical reasons or things that impact, I don't know that this really falls under ethical, but I definitely would want to know more about his mother and her depression and what kind of medication she is taking. There's just research out there that shows that medications that are effective for some family members can sometimes work in other family members. So I would like to know, you know, is she treated? What is she taking, and is it effective for her? I also would recommend that he begin psychotherapy due to his past history of childhood abuse. We know that trauma increases mental health conditions, and we need, you know, to make sure that that's being addressed as well, because just giving somebody medication is not always going to be the answer if they have some trauma that needs to be worked through. I would also further assess him to find out if he has any history of substance abuse himself, with the patient having childhood trauma and a father who was an alcoholic. It puts him at great risk for substance abuse as well. So I do think that we should have done a CAGE assessment at a minimum, and we should probably follow that a little bit further to see if he is using any substances. And I think that's answering all 12 of our questions.